Hello there. Uh, so we were studying gastroenterology, and let's move further on to the next question, next topic. Uh, so here we have a 39 years old patient who was recently diagnosed with celiac disease and has been treated with a gluten-free diet for 2 years. He now has an exacerbation of the classical symptoms of celiac disease such as abdominal pain, diarrhea, has significant weight loss. The biopsy of the small intestine shows lymphomatous infiltrates. What is the single most likely diagnosis? So here we have to keep in mind that lymphoma should be at the top of the list of answers when you see a patient with celiac disease in the exam. Lymphoma should be on the top. Enteropathy associated T cell lymphoma, that is EATL. Enteropathy associated T cell lymphoma is one of the complications of celiac disease. This tumor derives from the neoplastic transformation of aberrant intraepithelial T lymphocytes emerging in celiac patients unresponsive to a gluten free diet. The biopsy may show lymphomatous infiltrates accompanied by prominent mixed inflammatory infiltrates composed of histiocytes, small lymphocytes, plasma cells, and eosinophils, which may obscure the neoplastic cells. So, here we'll go with lymphoma. As we studied about celiac disease is an autoimmune condition caused by sensitivity to the protein gluten. Repeated exposure to gluten in rye, wheat, barley can lead to villus atrophy, and which can further lead to malabsorption. Clinical features would be chronic or intermittent diarrhea, steatorrhea, that is fat in stools, stinking stools, then persistent unexplained GIT symptoms such as bloating, nausea, vomiting, then fatigue, weight loss, vitamin B12, folate, and iron deficiency. Unexplained iron, folate, and B12 deficiency. Most common presentation of celiac disease is iron deficiency anemia. Folate deficiency is also very common along with vitamin B12 deficiency. In children, tapering of growth will be there. Complication can be first osteoporosis, second T cell lymphoma. Osteoporosis and T cell lymphoma. Investigations can be specific autoantibodies such as tissue transglutaminase antibodies, which are IgA type of antibodies, first choice according to NICE guidelines, and anti-endomysial antibodies. Anti-endomysial antibodies. And second is jejunal or duodenal biopsy. So biopsy is still required to confirm the disease, to confirm the diagnosis, even when specific antibodies are positive. These are present. And in biopsy, we'll look out for villus atrophy, crypt hyperplasia, increase in intraepithelial lymphocytes. In biopsy, there is villus atrophy, crypt hyperplasia, and increase in intraepithelial lymphocytes. These serological tests or biopsies for celiac disease, these are not accurate if a gluten-free diet is eaten during the diagnostic process. Therefore, patients should not start a gluten-free diet until celiac disease is confirmed by carrying out these biopsy and serological tests. Therefore, it can be distressing to patients as they would be continue to be symptomatic. So, if a patient is already taking a gluten-free diet, we have to advise them to reintroduce gluten in their diet for at least 6 weeks prior to testing. Management would be by gluten-free diet. So, celiac disease, malabsorption syndrome due to inflammatory response to gluten present in wheat, rye, barley. Presentation: chronic intermittent diarrhea, fatty stools, steatorrhea, abdominal distension, nausea, bloating, vomiting, chronic fatigue, weight loss, malabsorption of iron, folate, and B12 deficiencies. Then skin manifestations can be dermatitis herpetiformis. Skin manifestation of celiac disease is dermatitis herpetiformis, commonly seen on extensor aspects. Then investigation tissue transglutaminase antibody, anti-endomysial antibody, duodenal or jejunal biopsy. These are confirmatory, which have villus atrophy, crypt hyperplasia, increase in intraepithelial lymphocytes. Management is by gluten-free diet. For the test to be accurate, the patient should not should still for the test to be accurate, the patient should be having gluten in their diet, so they should not be on gluten-free diet. If the patient is already on gluten-free diet, then gluten has to be reintroduced in their diet at least 6 weeks prior to testing. And along with this, lymphoma should always be on the top of the list of answers when we see a patient with celiac disease. Enteropathy associated T cell lymphoma is one of the complications of celiac disease. The tumor derives from the neoplastic transformation of aberrant intraepithelial T lymphocytes emerging in celiac patients, which are not responsive to a gluten-free diet. Biopsy may show lymphomatous infiltrates accompanied by prominent mixed inflammatory infiltrate composed of histiocytes, small lymphocytes, plasma cells, eosinophils, which may obscure the neoplastic cells. So lymphoma is basically a group of cancers which develop from lymphocytes. These are of four types: Hodgkin's lymphoma, non-Hodgkin's lymphoma, multiple myeloma, and immunoproliferative diseases. Hodgkin's, non-Hodgkin's, multiple myeloma, and immunoproliferative diseases. Now let's diverticular disease is pertaining to symptoms caused by presence of diverticula. These are small herniations of mucosa and submucosa through the muscular wall of the colon. Whereas peritoneal tumor describes a cancer which forms from the peritoneal epithelium. These tumors can be primary or they can be metastatic in nature from sites such as ovaries, liver, and GIT. Complications can be fistula formation or adhesions. Okay, let's move further now. This we have to take care of the complications of celiac disease. That can be osteoporosis and T cell lymphoma or enteropathy associated T cell lymphoma, and it can also cause diabetes mellitus. Okay, let's move further. Now we have a 35-year-old man presenting to his GP surgery with a history of dyspepsia. Uh, so a 35-year-old man presenting to his GP surgery with a history of dyspepsia intermittently for the past 3 months. Serum antibodies for H. pylori were seen to be negative a month ago. There has been no improvement with his symptoms despite taking a proton pump inhibitor for the past 1 month. He reports no weight loss of blood in the stools, no previous history of NSAIDs, does not smoke, drinks a cup of coffee in a day. Abdominal examination reveals slight tenderness at the epigastric region without a mass felt. Single most appropriate next step here. So it's a case of dyspepsia, and here we have to study about dyspepsia and H. pylori testing. The patient is less than 55 years old, does not have any red flags, as his initial antibodies for H. pylori are negative. His symptoms have not resolved. It would be appropriate to refer this patient for an endoscopy. On the other hand, if his serum antibodies for H. pylori were initially positive, then a urea breath test would be more appropriate. So here, because antibodies for H. pylori are negative, Therefore, it is more appropriate to request for an endoscopy, to carry out an endoscopy for this patient. But if the serum antibodies for H. pylori were positive, then we would carry out a urea breath test. That would be more appropriate. So initially serum antibodies for H. pylori, then C13 urea breath test done as retesting to check after eradication. If still positive, then eradicate again. If negative, symptoms do persist, then we have to do endoscopy. But if elderly patient is there with dysphagia or other red flags, we have to do endoscopy directly. An endoscopy is also indicated for any patient with no response to proton pump inhibitors after 4 weeks. So the general management for dyspepsia and H. pylori testing. So general management for dyspepsia for patients less than 55 with no red flags. First, we have to try lifestyle modifications and antacids. If there is no improvement, then perform H. pylori antibody testing. If serum antibody is positive for H. pylori, then eradicate and review in 4 weeks. If resolved, no further action is required. If the symptoms still not resolved, then we perform a urea breath test. We perform a urea breath test. If positive, then we have to eradicate again. If it is negative, then we have to do upper GI endoscopy. But if after lifestyle modification antacids there is no improvement and we performed H. pylori antibody testing, if it is negative, then we prescribe proton pump inhibitors or H2 blockers for 4 weeks and then conduct a review in 4 weeks. If symptoms resolve, no action needed. If symptoms do not resolve, then upper GI endoscopy. So, if there is no response to lifestyle modifications and antacids, NICE recommends any locally validated test for H. pylori, which include the carbon 13 urea breath test, stool antigen test, or serum antibody test. So, if there is no response to lifestyle modification and antacids, then NICE guidelines recommend any any test, locally validated test for H. pylori, such as C13 urea breath test, carbon 13 urea breath test, stool antigen test, and serum antibody testing. In practice, if the patient is taking proton pump inhibitors, remember to stop it 2 weeks prior to performing urea breath test or stool antigen test. The only one test which we need to remember for retesting for H. pylori is to check for eradication, or for retesting for H. pylori is carbon 13 urea breath test, as NICE recommends this, as there is still insufficient evidence to recommend stool antigen test for eradication. To check for eradication, serological tests have no value in confirming successful eradication because antibodies can persist long after successful eradication. So once again, general management for a patient of dyspepsia less than 55 years with no red flags. First, try lifestyle modifications and antacids. If no improvement, then perform H. pylori antibody testing. If it is positive, If the serum antibody is positive for H. pylori, then we have to carry out eradication and review after 4 weeks. If resolved, no further action. If symptoms not resolved, then we perform a urea breath test, C13 urea breath test. If it is positive, then eradicate. If it is not positive, if urea breath test or stool antigen test or serum antibody testing, if these tests are not positive, then we have to conduct upper GI endoscopy and we have to go for endoscopy. Now, if we have tried lifestyle modification and antacids, no improvement, and then we have performed H. pylori antibody testing. If it is negative, if this test is negative, then we have to give proton pump inhibitors or H2 blockers for 4 weeks and review in 4 weeks. Give proton pump inhibitors, H2 blockers, and review in 4 weeks. Symptoms resolved, no further action. If symptoms not resolved, then carry out endoscopy. So therefore, NICE recommends any locally validated test such as C13 urea breath test, stool antigen test, or serum antibody testing. And we have to remember, if the patient is taking proton pump inhibitors, then we have to stop them at least 2 weeks prior to taking urea breath test or stool antigen test. But the only test which is valid or which is most accepted for retesting or to check for eradication is carbon 13 urea breath test, C13 urea breath test, which is recommended by NICE to check for eradication, because insufficient evidence to support stool antigen test and serum antibody tests are also not reliable to check for eradication, because antibodies can persist even after a long time, even after eradication has actually occurred. Now we'll study about H. pylori testing here. So H. pylori testing, which test to pick for initial testing? So it can be C13 urea breath test, stool antigen test, serum antibody testing. All are equally acceptable, depends on the local validation of these tests. NICE does not give any preference to any of these tests. Stool antigen is mostly used in primary care because it has the highest cost effectiveness, very cost effective stool antigen test. Serology has comparatively lower sensitivity and specificity. Urea breath test is not as easy to perform. But which test we will pick for retesting or to check for eradication? That is carbon 13 urea breath test, C13 urea breath test. And now, if duodenal ulcer are present with refractory or recurrent symptoms, if duodenal ulcer present with refractory or recurrent symptoms, then we carry out urea breath test. It should be arranged 6 to 8 weeks after starting initial eradication therapy. So urea breath test should be arranged 6 to 8 weeks after starting initial eradication therapy in patients who have a proven duodenal ulcer who have refractory or recurrent symptoms. If urea breath test is not available, then we do a stool antigen test. So NICE usually does not prefer any test, any of these three tests, carbon 13 urea breath test, stool antigen test, or serum antibody testing. All of them can be used for initial testing of H. pylori. But stool antigen is most commonly used in primary care, stool antigen test, because it is very cost effective. Serology has lower sensitivity and specificity. C13 urea breath test is not that easy to perform. But for retesting and check for eradication, NICE recommends C13 urea breath test. carbon 13 urea blood test. And but if duodenal ulcer are present along with refractory or recurrent symptoms, then we have to conduct urea blood test after around 6 to 8 weeks after starting the initial eradication therapy in the patients who are having duodenal ulcer plus refractory or recurrent symptoms. If this test is not available, then we will go for stool antigen test. So here, as the initial antibodies for H. pylori are negative, if symptoms have not resolved, so we would refer this patient for an endoscopy. And also proton pump inhibitors have been given in the past, because we studied that first we will try lifestyle modifications and antacids. If they are not working, no improvement, then H. pylori antibody testing. If it is positive, then we carry out eradication and review in 4 weeks. If it's resolved, no further action. If it is not resolved, then perform urea blood test. If it is positive, eradicate again. If it is not positive, then perform endoscopy. If H. pylori antibody testing is negative, if serum antibodies for H. pylori or antibody testing for H. pylori is negative, then we will give proton pump inhibitors or H2 blockers for to the patient and review in 4 weeks again. If it is resolved, no further action. If it is not resolved, then again endoscopy has to be performed. Okay, let's move further. A 33-year-old man is recovering from a major burn injury. He sustained a 40% partial thickness burn during a house fire. He has started vomiting blood, experiencing epigastric pain over the past 24 hours. He has total estimate of 350 ml of bright red blood seen when vomiting. IV fluids have been started. Endoscopy reveals several gastric ulcers, of which endoscopic treatment followed. Single most appropriate management here. So, stress induced ulcers of the stomach may occur in massively burned patients. It is also called as Curling's ulcers. So, Curling's ulcers are seen in patients of burn. These are stress induced ulcers of the stomach which may occur in massively burned patients, also called as Curling's ulcers. In this, intravenous proton pump inhibitors are used to reduce the risk of bleeding. It can be switched to oral therapy after 72 hours. So, if the patient is having stress induced ulcers, if the patient is having stress induced ulcers in case of a major burn, in case of a major burn injury, if the patient is having stress induced ulcers called as Curling's ulcers, then intravenous proton pump inhibitor should be given for at least initial 72 hours. We can then change to oral therapy after 72 hours. Switch to oral therapy after 72 hours. So Curling's ulcer, stress-induced ulcers and major burn, intravenous proton pump inhibitors. Switch to oral proton pump inhibitors, oral therapy after 72 hours. Okay, let's move further. A 41-year-old lady attends the clinic complaining of long history of mild pruritus and fatigue. She looked jaundiced. Alkaline phosphatase was raised on routine liver function. She was diagnosed with Sjogren's syndrome a few years back. What is the single most appropriate test to perform to help make a diagnosis here? So here we have to study about primary biliary cirrhosis. That is the diagnosis here. The diagnosis here is primary biliary cirrhosis. The classic presentation is itching in a middle-aged woman, as we see here. Middle-aged woman complaining of itching. That is pointing towards primary biliary cirrhosis. Long history of mild pruritus and fatigue. She looked jaundiced as well. So this is primary biliary cirrhosis. Alkaline phosphatase were also raised. Now often asymptomatic and diagnosed after finding alkaline phosphatase on routine LFT, lethargy, sleepiness and pruritus may precede jaundice. Pruritus, lethargy and sleepiness may precede jaundice. There is an association with Sjogren's syndrome. Primary biliary cirrhosis has an association with Sjogren's syndrome, and antimitochondrial antibodies are the hallmark for this disease. So to help remember, we have to think of the M rule for primary biliary cirrhosis. That is, middle-aged females, antimitochondrial antibodies, and IgM. So, primary biliary cirrhosis. Primary biliary cirrhosis, also known as primary biliary cholangitis, is an autoimmune disease of the liver which results in slow progressive destruction of the intrahepatic bile ducts. The destruction leads to cholestasis followed by fibrosis and eventually cirrhosis. So primary biliary cirrhosis, also called as primary biliary cholangitis, it is an autoimmune disease of the liver which results in slow progressive destruction of the intrahepatic bile ducts. Slow progressive destruction of the intrahepatic bile ducts, which further, and this destruction of intrahepatic bile ducts leads to cholestasis followed by fibrosis and eventually cirrhosis of liver. Presentation: 50% of the patients with primary biliary cirrhosis are asymptomatic. If the symptoms are present, they can be pruritus, fatigue, and obstructive jaundice, which is a late sign. In the exam, patient would be more likely to be a middle-aged female because the ratio of PBC found in women to men is 9:1. So primary biliary cirrhosis is very common in middle-aged female. The ratio of women to men is 9:1. The family history of autoimmune conditions such as thyroid disease, celiac disease, Sjogren's syndrome, scleroderma are commonly seen. So family history of autoimmune conditions such as celiac disease, thyroid disease, Sjogren's syndrome, scleroderma are commonly seen. Investigations would be alkaline phosphatase is raised, cholestatic picture, and antimitochondrial antibodies are positive. AMA, antimitochondrial antibodies are positive, and ALP is raised. Management is ursodeoxycholic acid and cholestyramine. So management involves ursodeoxycholic acid and cholestyramine. So again, primary biliary cirrhosis, also called as primary biliary cholangitis, it is an autoimmune disease of the liver which results in slow progressive destruction of the intrahepatic bile ducts. This destruction leads to cholestasis and later into fibrosis and cirrhosis of liver. 50% of the patients are asymptomatic, but if symptoms are present, they will be like pruritus, that is itching, sleepiness, fatigue, and obstructive jaundice. Obstructive jaundice is a late symptom, is a late sign. Obstructive jaundice is a late sign. Now, most commonly it affects middle-aged women because the ratio of primary biliary cirrhosis in women to men is 9:1. And it is usually associated with the family history of autoimmune conditions. Family history of autoimmune conditions is very important, significant here, such as thyroid disease, celiac disease, uh, Sjogren's syndrome, or scleroderma. These are commonly seen. There is common association with other autoimmune conditions in the family. Family history is significant. Investigations would be here alkaline phosphatase would be raised, cholestatic picture. Alkaline phosphatase is raised, and second, anti-mitochondrial antibodies. In primary biliary cirrhosis, we will see anti-mitochondrial antibodies, IgM. Anti-mitochondrial antibodies are positive here, and management would be with ursodeoxycholic acid and cholestyramine. So we have to keep in mind three M's, that is middle-aged females, anti-mitochondrial antibodies, and IgM. Presentation would be pruritus, that is skin excoriation, jaundice, sleepiness, fatigue, pruritus, itching, jaundice, which is a late sign, obstructive jaundice. Alkaline phosphatase would be raised, anti-mitochondrial antibodies would be found. Alkaline phosphatase is raised and it is associated with other autoimmune conditions such as thyroid disease, celiac disease, Sjogren's syndrome, scleroderma, etc. Treatment is ursodeoxycholic acid and cholestyramine. Female predominance is there. Ratio of women to men is 9:1. So we can memorize by like this: primary biliary cirrhosis. B can be memorized by relation to breasts, that is found in women. So it is having a female predominance. PBC, primary biliary cirrhosis, breasts in women, predominance 9:1 ratio. Now here we will also see primary sclerosing cholangitis. So primary biliary cirrhosis and primary sclerosing cholangitis, we have to see both of them. First, let's go through primary sclerosing cholangitis. Here, presentation would be pruritus would be present, jaundice would be present, alkaline phosphatase would be raised, but it is associated with ulcerative colitis. It is not associated with Autoimmune conditions such as thyroid disease, celiac disease, Sjogren's syndrome, or scleroderma, like in primary biliary cirrhosis, which is more commonly found in women, 9 is to 1 ratio, female predominance. But here, primary sclerosing cholangitis, because primary biliary cirrhosis also called as primary biliary cholangitis, whereas this primary sclerosing cholangitis is found more commonly in men. Ratio of men to women is 7 is to 3. Here it is male predominance and it is associated with ulcerative colitis. Memory tool, primary sclerosing cholangitis, S as for men's stick. So yes, we can remember like that. Treatment in primary biliary cirrhosis, it was ursodeoxycholic acid and cholestyramine. Here it is supportive. Cholestyramine reduces the itch and liver transplant for end stage disease. So primary biliary cirrhosis, 3M, anti-mitochondrial, middle-aged women, anti-mitochondrial antibodies, IgM. Presentation would be uh, pruritus or itching, and fatigue or sleepiness, and obstructive jaundice, which is a late sign. Then investigation, alkaline phosphatase would be raised. Cholestatic picture, alkaline phosphatase would be raised, and second, anti-mitochondrial antibodies are found. Then it is associated with primary biliary cirrhosis is associated with autoimmune conditions such as thyroid disease, celiac disease, Sjogren's syndrome, scleroderma, etc. It has female predominance. Women to men ratio is 9 is to 1. Primary biliary cirrhosis, PBC, B for breast, found more in women. Treatment, uh, found more in women, that is primary biliary cirrhosis. Now treatment would be ursodeoxycholic acid and cholestyramine. Coming to primary sclerosing cholangitis, PSC, S for stick, man's stick. So it is having a male predominance. So it is more commonly found in men. The ratio from men to women is 7 is to 3. And here also we will have pruritus. The symptoms presentation would be having pruritus. Then jaundice would be there, alkaline phosphatase would be raised, but this is not associated with autoimmune condition. This is associated with ulcerative colitis. And here the treatment would be cholestyramine, which will help in reducing the itching or help in relieving the pruritus. And so the first treatment would be cholestyramine, which will reduce the itching or help with the pruritus, and second would be liver transplant for end stage liver disease. Cholestyramine reducing the itching or pruritus, which is supportive, and liver transplant for end stage liver disease. So this is about primary biliary cirrhosis and primary sclerosing cholangitis. Let's now compare uh, both primary biliary cirrhosis and primary sclerosing cholangitis. Primary biliary cirrhosis, it is autoimmune, idiopathic. This is also autoimmune and idiopathic. PBC is having female predominance, PSC is having male predominance. PBC is having association with autoimmune conditions such as thyroid disease, celiac disease, Sjogren's syndrome, scleroderma. It is having association with ulcerative colitis, inflammatory bowel diseases. This is having pruritus and alkaline phosphatase would be raised. It is also having pruritus and alkaline phosphatase would be raised. Jaundice can also be present. Here also jaundice can be present. Here, anti-mitochondrial antibodies are positive in primary biliary cirrhosis. Anti-mitochondrial antibodies are positive. In primary sclerosing cholangitis, ERCP, that is endoscopic retrograde cholangiopancreatography, is the most specific test. Here, the management involves ursodeoxycholic acid and cholestyramine. Here, management involves cholestyramine, reducing the pruritus, itching, and liver transplantation for end-stage liver disease. Okay, now let's move further. So, severe sudden right upper quadrant pain, that is biliary colic. There is severe sudden right upper quadrant pain, that is biliary colic. If right upper quadrant pain with fever and chills, that is acute cholecystitis. If right upper quadrant pain plus fever plus jaundice, then that is ascending cholangitis. If there is postpartum right upper quadrant plus pruritus, that is obstetric cholestasis. If pruritus in middle-aged women plus antimitochondrial antibodies plus association with Sjogren's syndrome, primary biliary cirrhosis. If pruritus with ulcerative colitis or Crohn's disease, because you have inflammatory bowel disease, plus diagnosis by ERCP, that is primary sclerosing cholangitis. If there is abnormal LFT plus secondary amenorrhea plus any autoimmune disorder, autoimmune hepatitis. So it's just a quick run up. If severe sudden right upper quadrant pain, biliary colic, right upper quadrant pain with fever and chills, acute cholecystitis. If right upper quadrant pain with fever and jaundice, then ascending cholangitis. If right upper quadrant postpartum plus pruritus, then obstetric cholestasis. Uh, if pruritus in middle-aged women plus antimitochondrial antibodies and association with Sjogren's syndrome, then primary biliary cirrhosis. If pruritus plus ulcerative colitis or Crohn's disease plus diagnosis by ERCP, primary sclerosing cholangitis. Abnormal liver function test, secondary amenorrhea, or any autoimmune disorder, then autoimmune hepatitis. Okay, let's move further. Now we have a 36 years old woman presenting with the complaint of a right-sided abdominal pain which began 2 days ago. She also complained she has been feeling drained with a generalized body ache, joint pain, feeling nauseated for the past 10 days. She vomited twice this morning, at least thrice over the past few days. She noticed that her urine is darker than usual. Stool appears somewhat pale, which she has never been the case in the past. She does not have a past medical history of note apart from social drinking. She neither smokes nor uses recreational drugs. Furthermore, she did not travel overseas in the recent past. Her only outing was a date to a seafood restaurant a month ago. Her partner also developed similar symptoms 2 days ago. On examination, she is icteric with a temperature of 38, blood pressure 110, 80, heart rate 110. Examination of abdomen, a few scratch marks are noted. She admits to having itchiness. Few scratch marks, and she admits to have itchiness. Additionally, there is an enlarged and tender liver. Enlarged and tender liver is palpable. Liver function test is requested. Results are bilirubin 30, which is raised. Alkaline transferase is 1100. Aspartate transaminase is 350. Alkaline phosphatase 180. So now, which of the following is the most appropriate investigation to request? So this is a case of hepatitis A. The most likely diagnosis is an infection with hepatitis A. The virus has an incubation period of 4 weeks on an average, which tallies with the patient's past medical history of eating out a month ago. Another important point is her partner's similar complaint of feeling unwell. Shellfish are known to be reservoirs of hepatitis A, and the mention of a seafood restaurant is a valuable point in favor of the diagnosis. Hepatitis A, unlike hepatitis B, is transferred by the fecal-oral route. In the case of viral hepatitis, ALT is much higher than AST, which is the case here. Here, ALT is much higher than AST. Therefore, it is a case of viral hepatitis, although both are elevated here. IgM antibodies to hepatitis A virus are detected around the time symptoms develop as opposed to IgG antibodies. IgM antibodies to hepatitis A virus are detected around the time symptoms develop as opposed to IgG antibodies, which are detectable soon after IgM and can remain detectable for several years. HBs antigen, HBe antigen, anti-HBC antibodies are useful in the detection of hepatitis B, not A. So, so this is a case of hepatitis A. Now, studying about hepatitis A, the mode of transmission is fecal-oral route. Clinical features: pruritus, that is nail or scratch marks observed on the abdomen or limbs. Fever may not always be present. Then prodromal symptoms such as myalgia, arthralgia can last 2 to 3 days. Pain in muscles, pain in joints, myalgia and arthralgia can be present lasting to 2 to 3 days. Then icteric phase. Icteric phase, we will have symptoms like dark urine, pale stools, jaundice, and abdominal pain. So in icteric phase, there will be dark urine, pale stools, and jaundice and abdominal pain. Then tender hepatosplenomegaly. In case of investigations, in the case of viral hepatitis, ALT and AST both are often elevated with an ALT to AST ratio more than 2. So ALT is much more raised than AST in case of viral hepatitis. ALT is much more raised than AST. Ratio ALT to AST can be more than 2. ALP is elevated, bilirubin is elevated, alkaline phosphatase is also elevated, bilirubin is also elevated. Anti hepatitis A IgM antibodies, these are detected around the time symptoms develop, whereas anti-hepatitis A virus IgG antibodies. These are detectable soon after IgM and they remain detectable for life for several years. The presence of IgM, irrespective of the patient's IgG status, indicates an acute infection. If IgM antibodies are present, it indicates acute infection, that is recent infection, while the presence of an isolated IgG implies that the patient had been infected in the past, not necessarily now, because they can persist in the body for a long time, for life even, several years. Management, supportive management with fluids, antiemetics are the mainstay of management in the majority of the cases. Second, hospital admission will be required if the patient is systemically unwell. Hepatitis is a notifiable infection and Public Health England must be informed of the same. So, in hepatitis A, the mode of transmission is fecal-oral route. Clinical features would be pruritus, that is itching. So we will see nail or scratch marks on the abdomen or limbs. Then fever may or may not be present. And prodromal symptoms such as myalgia and arthralgia can be present for 2 to 3 days. These are prodromal symptoms, arthralgia and myalgia. They can be present for 2 to 3 days. Then in the icteric phase, we will see dark urine, pale stool, jaundice, and abdominal pain. In the icteric phase, dark urine, pale stool, jaundice, and abdominal pain, and we will see tender hepatosplenomegaly. In hepatitis A, we will see tender hepatosplenomegaly. Investigation in case of viral hepatitis, ALT is much more raised than AST. Alanine transaminase is much more raised than aspartate transaminase. So ALT is much more raised than AST, and ALT to AST ratio is more than 2. Both can be elevated. Other than that, other investigations are alkaline phosphatase is also elevated, bilirubin is also elevated, then anti hepatitis A virus IgM antibodies, these are usually appearing at the same time when the symptoms develop. Therefore, the presence of these IgM antibodies detect acute infection or the recent infection, whereas other antibodies like anti-hepatitis A virus IgG antibodies, they can actually persist in the blood. They can persist in the serum for a long period of time, for many years, even for life. Therefore, finding those antibodies, IgG antibodies, does not indicate any recent infection necessarily. They can they can point towards patient being infected in the past. So ALT, AST, alkaline phosphatase, bilirubin, then IgM and IgG antibodies to hepatitis A virus. Anti-hepatitis A virus, IgM antibody, anti-hepatitis A virus, IgG antibody. Now management would be supportive management with fluid therapy and antiemetics is the mainstay of the management and will be useful in the majority of the cases. Hospital admission is required if the patient is systemically unwell. Hepatitis is a notifiable infection, and Public Health England has to be informed of the same. It is a notifiable infection, hepatitis. Therefore, Public Health England (PHE) has to be informed of the same. Okay, so this was about hepatitis A, which was the likely diagnosis here, and this virus has an incubation period of 4 weeks. So it was implying it tallies with the patient's past medical history of eating out, and shellfish are considered to be reservoirs of hepatitis A. Shellfish are considered to be reservoirs of hepatitis A. Therefore, eating out in a seafood restaurant is also significant here, a valuable point in the favor of the diagnosis, because shellfish are natural reservoirs of hepatitis A, are known to be reservoirs of hepatitis A. And HBs antigen, HBe antigen, and anti-HBC antibodies, these are useful in the detection of hepatitis B. Now let's move further. A 21-year-old man has been brought to emergency by his friends as he is having a yellow sclera and yellowing of the skin. He has recently been having flu-like symptoms and a non-productive cough. A urine dipstick was performed, was normal. Blood results are hemoglobin 129, reticulocytes 1.2%, bilirubin 44, alkaline phosphatase 88, ALT 24, albumin 42. What is the single most likely diagnosis here? So this is a case of Gilbert syndrome. We'll study about Gilbert syndrome in a while. Let's take a break, small break, and I'll be back.